Good evening friends, and welcome back to the Thursday evening PG teaching session brought to you from LTMMC Sion Hospital, Mumbai. Once again we thank the authorities at Sion Hospital, especially Dr. Radha Gildial Madam and the Dean of Sion Hospital for allowing us to conduct these classes here, and we also thank Aristo Pharma for an educational grant which facilitates the live webcast of these classes. Today we have two cases. The first case is being presented by Dr. Namrata from Hinduja Hospital, Mumbai. So Dr. Namrata.
This is the case of a 12-year-old boy, second by birth order, born of non-consanguineous marriage, hailing from Kalyan, Christian by religion, brought by parents with chief complaints of on and off neck pain since 3 years, aggravated since 2 months, weakness of all 4 limbs since 2 months, difficulty in breathing since 2 days. Informant is mother and is reliable. History of presenting illness: child was absolutely alright 3 years ago, after which he had a trivial fall at home. Child slipped and assumed a sitting posture with legs extended and arms by the side of the body. There was no impact to the head. Following the fall, child complained of neck pain, on and off, not associated with swelling over the neck or restriction of movement, mild intensity, not disturbing his activities or sleep, no aggravating factors, relieved on local application of balms or ointments. Since the pain was mild and parents associated it with the fall, they did not seek any medical help initially. He continued to have this mild pain 3 to 4 episodes in the following year. When they consulted a local practitioner, X-ray was done and was told to be normal. He was advised some exercises at home, for which, after which he was symptomatically relieved. Now since 2 months, he has complaints of severe neck pain, progressive in nature, worsening intensity, disturbing his sleep and activities, continuous, not relieved with analgesics, associated with restriction of movement of neck. Mother also noticed slight swelling of left side of the neck and shoulder since 2 months, insidious in onset, non-progressive, not associated with redness, warmth or any skin changes, but was associated with deviation of head to the right side. He also started turning his entire body to the other side, to look to the other side. This was associated with shock-like sensation in the left upper limb. For the above complaints, child was taken to the outside hospital, investigated for the same, MRI was done, parents were told regarding the possibility of tuberculosis, and child was started on anti-tubercular treatment. After 9 days of starting the anti-tubercular treatment, child gradually developed weakness in the left upper limb. Initially, he was unable to move his arm above the shoulder, and in the next 2 to 4 days, he was unable to grip objects in his hand. He also developed weakness of both the lower limbs in the form of inability to bear weight. Left side was more weak than the right side, and mild weakness of the right upper limb in the form of inability to lift the arm above the shoulder and weak grip. Child also had difficulty in passing urine in the form of straining. He passed every 30 minutes to 1 hour, and 1 day later he also started complaining of difficulty in breathing. He was unable to put efforts to breathe. There was no fast breathing or abnormal chest movements. Child was again taken to the hospital in view of progressive weakness. He was taken for emergency surgery. Post-surgery, he was extubated, but there was minimal improvement in weakness of limbs. Flickering of the fingers were present. There was no difficulty in speaking or swallowing, no drooling, regurgitation of feeds. He was discharged with advice to continue anti-tubercular treatment and exercises. At home, there was no further improvement in weakness. Child was confined to bed, but he could speak and swallow. He still had complaints of difficulty in passing urine and breathing. Now, since 2 days, breathing difficulty increased further, and he had 1 episode of uprolling of eyeballs and bluish discoloration of lips and tongue. Child was immediately taken to the outside hospital. He was intubated and referred to our hospital for further management. Negative history: there's no history of altered sensorium, no history of involuntary movements, no history of cranial nerve involvement, no history of abnormal speech, no history of coughing or regurgitation of feeds, no history of headache or vomiting, no history of constipation, loss of sensations. Child could perceive, touch, pain, cold and hot sensations. No history of abnormal sweating or giddiness, no history of fever, loss of weight or loss of appetite, chronic cough, TB contact. And during this course of 2 months, child also developed ulcer over back of the head. Past history, there's no history of hospitalization prior to this illness. Birth history, antenatal was uneventful, full-term normal vaginal delivery, birth weight of 3 kg, cried immediately after birth, no history of NICU stay. Developmentally, he was appropriate for age, studied in 7th standard, good at academics. Immunization, he was immunized as per national immunization schedule, BCG scar was present. Family history was also not significant. Dietary history was appropriate. And socioeconomic history, he belongs to upper middle class as per modified Kupuswamy classification.
Yeah. So, what do you think of the initial history, the fall and the neck pain? Any thoughts about that before the things progressed? Any comments or what comes to your mind?
The fall could have been coincidental because there was no evidence of head trauma or injury to the neck.
So when you say fall could have been coincidental means what? Means the fall caused the neck pain or the fall didn't cause the neck pain?
They both were unrelated.
They both were unrelated. Why do you say so? Because you say there was no injury to the neck.
There was
Any other reasons?
It was a trivial fall. Trivial fall.
Okay. So you can get a muscle pull even in a trivial fall, no? Muscles pull, sprain, whatever. So why was it not that, or what are your thoughts?
Even with sprain, there can be restriction of movement or pain on a certain movement.
Yeah, so you're saying it was not there that day. So what are the bigger reasons why the fall and the neck pain may be unrelated?
The pain should have been highest during the fall. I mean, it was not very severe, and it went on for a long time, on and off. It was a muscle strain. It should have been present every time there was some movement of the head, but being on and off, and it also went for a long time. And it was intermittent and went for a long time.
Yeah.
I think at this age, the fall, whatever the fall, the neck pain is very unusual. That's the first thing.
Hold it close.
And to that extent, one would take it seriously till proved otherwise. Okay. It was a trivial fall, and the description is he just sat down, okay, with extended legs, okay, arms, which means that he certainly lost his balance. When he loses his balance, there could be a stretch, especially of the neck. And therefore, with this history, I would certainly not neglect the pain. Now imagine, when did anybody fall and complain of neck pain? Okay, while it is possible, only if there was a serious injury, and the serious injury means he lost balance. When he loses balance, he tries to kind of control, and in the process might just get a stretch and get pain. So first thing is, take any neck pain seriously. That is number one. Then, if it was without swelling, correct? We are looking at a child whom we saw immediately after a fall. Okay, and he came to you saying, it's hurting. What would you do? You would look at the swelling, you could look at the movements, everything is fine. What would you have told the parents or the child? Go home, don't worry, or watch for something, and if not, then let me know. What would be, any thoughts on that? Am I clear on the question? Any thoughts? Come on. Because what is important? See, now we have got the whole story, so we are imagining what must have happened. But on day one, it was most difficult to make out, but we have logically said, neck pain after a fall, just don't ignore. In fact, any neck pain, don't ignore. That's not a common site of pain. Physiological, traumatic, benign, no. What would you have done on day one?
Come on, think and tell us.
Guesswork. See, we are learning how to approach a problem. Okay, at the end you will do, I'll do an MRI, I'll do neurology consult. Yes, you will know.
So see, sir has already told two things. First, he has said that take that pain seriously. And now he said MRI. So question is, that day, first day, would you have told the patient, no, this is serious pain, we should do MRI just now? No. So what would you have said?
If the child develops any complaints in the due course of time, like any tingling sensation, any bowel, bladder issues, any weakness of the limbs, I'll ask the parents to look for.
So any neurological symptoms, immediately report. But what else would you say? See, you start with the presumption that you are already taking this pain as not related to the fall. So in that context, what else will you say?
See, your answer is right, but the parents or the 12-year-old will not forget to report he can't move the limb. So you have to first tell him what are the subtle symptoms that they may ignore, like they ignored these symptoms. That is important. You are right. Okay. So what would you have done? So you would have said, if pain persists over next 2-3 days, come back, let me examine.
See, you just now said that any traumatic pain is max at onset and then it has to quickly go down. So that's the first thing we would have told them, that in 2-3 days, 5 days, this pain doesn't go, means there's a problem.
Right? Now he comes back after 2-3 days, says, the pain has not increased, but pain has not disappeared also. You examined him, there is no localized tenderness, localized swelling, neurology is normal. Now what do you do? So let's trace the understanding of the whole disease, right? In a tertiary hospital in the city, we are lucky to see the last stage of the disease and wonder why the fellows earlier did not understand. Okay, we are trying to learn what they should have done, what we would also not done. So what would you have done? After 3, 4, 5 days, same thing, nothing different. Now what do you do? Give a thought, doesn't matter. Nelson won't give this. Okay.
So in other words, now you know, you are thinking that this has nothing to do with the fall, so you are thinking there is a problem. What are the possible problems that you are thinking that will decide your actions? So what possible problems could give, what is the anatomy of this pain now? Could be?
A fracture of cervical spine, small fracture.
Okay.
Without
So
any
now-
neurological involvement, just fracture causing pain for 3 to 4 days, persistent pain.
Okay, so now 2-3 things. One is, when would you get a fracture of a cervical bone? Come on, list the conditions.
So there
First
should be
is major trauma. Don't just say trauma, say major trauma. And if it is in the absence of major trauma, then
concussion
a-
injury.
it is a pathologic fracture. So you start thinking of that. Second, if it is a fracture, would it lead to a mild pain which is persistent for 4-5 days?
No.
Oh, it should be significant pain, right? Okay, what else? What could be causing this pain? So anatomy. Is it bone? Is it muscle? Is it nerve? What is it? Come on,
Involvement of nerve will not just cause pain, it will cause some neurological symptoms.
Okay.
So another can be muscle pull.
Okay. So muscle pull. So can you clinically make out a muscle pull? What happens when there is a muscle pull?
Clinically, it's difficult to make out because there is
Why?
no.
If I have a back muscle pull, It's so easy to make out. I can't walk straight only. Why?
Increases on strenuous activities. It increases on strenuous activities. When you strain that muscle.
So most muscle pulls go into a spasm. No, that muscle goes in a spasm, right? So it's relatively easy to make out a muscle pull, right?
So I think at that stage, we would have said this is a pathological pain, but I can't find even evidence of any lesion. In other words, there is no tenderness. Okay, his movements are fine. What kind of pain that must be? When we cannot see, a neck pain of that kind is not skin or subcutaneous tissue or muscle. It is a bone. Okay, trivial injury and a bone pain. Okay, what does it mean? Injury was trivial, but there was already some abnormality existing maybe. Okay, therefore it picked up a symptom. So do I have a child who has some abnormality prior to the fall there, silent? Okay, that's one possibility. Second possibility is that was the injury so mild? Well, it was if so mild, it would have disappeared. Why is it persisting? So now you start thinking, what is the pathogenesis of this pain? Is it inflammatory? Is it vasogenic? Is it neurogenic? Is it referred? Or is it psychogenic? Whenever you can't place the anatomy clearly, go a bit further and say, let me see where is the anatomy. After all, nerve is an anatomy. Inflammation, mostly bone nerve. So, where is this pain? Make a guesswork. Now we are seeing him at 10, 12, 15 days of time. No change, persistent, no worsening. So I will add one more adjective, static disease. And static disease may be slowly progressive disease. We have seen in neurology, okay, what looks like cerebral palsy may be a slowly coming up neurometabolic disorder. So two options, static or slowly progressive in a child who may have had already a silent problem or first time an acquired problem which is growing very slowly because it's not disappearing. Therefore, possibly slowly growing. Where must be the pain? Inflammatory? No. Vasogenic? No. So neurogenic. On day 10, you would have said, I am worried you have a neurogenic pain. Okay. Where is it coming from? Still I don't know. Okay. But it's a neurogenic pain. Now obviously neurogenic pain could be injury to the nerve directly coming from surrounding area, vertebral column, whatever. But we have picked up now, anatomy of this pain is nerve, and therefore a pathology is nerve there, but is secondary to something. Could it be primary nerve problem? I have several types of neuritis, no? Mononeuritis, primary. Why do I want to pick up secondary cause? What is your answer to that? Could it be mononeuritis? You have heard the term mononeuritis, polyneuritis. Okay. Then we won't look at any other pathology.
So what are the sites of all these mononeuritis and all that? Is it ever in the neck?
So first answer should have been a common nerve lesion start from the periphery. We have done that, no? Muscles. So this is not neuritis, but secondary to something. What is secondary to something? The bone. Okay, that's where it is. Now what kind of bone? Trauma? Congenital malformation that caused trivial trauma to manifest? Or a tumor that's going to grow slowly? We would have started thinking of that kind. Okay, and if it was any acute injury, there would have been no time to say mild pain over time. It would have been a severe pain. So this is a slowly growing thing. Slowly growing is unlikely traumatic. Okay. And what is slowly growing? Only two. Degenerative or infiltrative. Okay. Both grow slowly. Could it be degenerative? Degenerative grows slowly, no? Degenerative nerve lesion slowly. Okay. So could it be degenerative? If not, it has to be infiltrative, means tumor, mass, whatever. Wherever coming from, we don't know still. What do you think? Could it be degenerative?
Degenerative nerve disease at this site, at this age, without other areas getting affected.
Out of question. So diagnosis in the first week could have been a coming up space occupying lesion. Okay. From where it's coming, I don't know. Primary or secondary. Which are cancers which are hidden but have a bony secondaries. And bony secondaries are the first manifestation of a primary site.
Neuroblastoma.
Excellent. So my first diagnosis is neuroblast. I mean, I'm not talking about the diagnosis. I'm talking about the thought process behind thinking. But okay, that's I think where we go on. But it has gone on for a long time.
Yeah, 2-3 years you said.
So
no?
benign mass or slowly growing malignancy. Now,
Okay. Now, someone just interpret this slide, the progress. So, last 2 months severe neck pain and that swelling and this the restriction of movement. So, can you just interpret this? What is happening? Any thoughts? Yeah.
It is a non-inflammatory swelling.
Okay.
So
Non-inflammatory,
now
why?
it's involving cartilage and all things. So
You can bring 2 chairs and sit here so that it's easy to discuss. Sorry, non-inflammatory?
it's causing involvement of ligaments and surrounding structure, leading to restriction of neck movements.
Okay. So restriction of movement happens why? Basic physiology, why will my neck restrict movement?
Could be due to pain.
Very good. So restriction of movement is almost always to guard against pain. Okay, wherever. So your neck stiffness is also a kind of restriction. Your abdominal guarding rigidity is same. Your hip restriction of movement is same. Everywhere it is to guard against pain. Okay, so the muscle goes in spasm. And in fact, that's why it's mentioned that a deviation of the head to the right side and he had to turn his whole body. So that whole muscle was so much in spasm that he couldn't turn his neck, right? And what about that swelling? Swelling on the left side, what is that swelling? What could that be?
It was actually not the defined.
Hold close, like this, hold like this.
It was not actually the well-defined swelling. It was because kind of torticollis. She felt this was more prominent than the other side.
Right. So because the muscle was in spasm, she could have thought that it is a swelling, or if it is any other swelling, then whatever we have been discussing as infiltration, SOL, that might have started showing up. It could be a growth, it could be a collection, it could be anything, we don't know right now, right? Okay.
and I think when it has gone on for a long time, you could also think about a slowly growing infective disease. We will not rule that out. So it looks like a too long a process, but how would a tuberculous disease present with an abscess, cold abscess? Okay, it won't be very severely painful to begin with. Nerves are involved, getting more and more. Okay, but the whole area is so small that it should not have taken such a long time to come up, whatever the reason. So there is something certainly amiss on that. But We will have to look at that. The third process is slowly worsening infection or infiltration. All right? Fine.
Trivial fall and neck involvement, car seat belt injuries, something that we should not miss out on. And the second one is if you have a downs with a trivial fall, yes, you start thinking. You need to give more importance to such a scenario.
Yeah. So in the first thing which Sridhar said, car seat belt injury, what is the other thing that is happening which leads to that neck injury?
Traction injury.
Traction as in the neck is not being pulled. There's a lot of momentum, no? There is so much force and momentum happening and then suddenly there's a jerk. So that jerk causes the injury. And what about Downs? What did he say about Downs?
Atlantoaxial dislocation.
Okay, fine. Okay. Now, after starting AKT, all these weakness developed. So what is your, why did this happen after AKT? Did AKT cause it?
So it could be the progression of the disease itself.
Okay. So it's just coincidental. It is not that ATT did that. It is just that ATT is yet to take action, and as a natural course of the disease, we have reached this stage, right? Okay. Then you said there's bladder bowel involvement. Bladder, difficulty in passing urine. Why is that so?
So UMN, like spinal cord involvement.
Okay. So it is a spinal cord involvement which involves the bladder leading to any kind of a dysfunction. So it could be retention, it could be anything, right? Okay. Then what about difficulty in breathing?
Involvement of the phrenic nerve.
Okay. So involvement of the phrenic nerve leading to diaphragmatic paralysis, that's a possibility, right? Okay.
Efforts for breathing means what? Will it be central? He is not able to make an effort only. Could it be central? No effort coming from center.
Answer?
Sensorium is okay, there's nothing suggestive of brain.
So if we just use those words, then yeah, it can be central. But here we know that the sensorium was fine. He was totally aware of his surroundings. So when he wanted to breathe, his muscles were not kind of siding with him or doing what he wanted to do. So in that sense, he could not make the effort to breathe, right? Okay, fine. So I think that's in the history. Okay, now what happened, this uprolling of eyeballs, what do you think this has happened? So others, what are your thoughts on this?
A hypoxic damage could have been the trigger.
Okay, one thought is hypoxic damage. Anything else? So means
The disease had either progressed to the cortical level.
Okay. So second is disease has progressed to the CNS. Okay. So now debate both these possibilities. What are the points for, against? So hypoxic seizure in a 12-year-old. What else should have happened at that time? What I mean is, we just mentioned that his sensorium was okay. So was he restless? Was he showing other changes in sensorium? Because this is not like a sudden hypoxia, no, like a 1-minute hypoxia. He is going into it gradually. So I don't think this kind of a situation will lead to a hypoxic seizure. Before that, the child would have many other manifestations, right? And what about disease spreading to the CNS? So is it TB meningitis now, or is it TB encephalitis, or what is it? So again, the details are very important. What is the sensorium and the condition of the child just before this event occurred, right? I mean, TB meningitis encephalitis is totally out, but still I'm saying that you need to know all the details of what happened just before this seizure occurred.
Actually, any injury can, within a short period of few weeks also, could develop a tuberculous focus at an injury site. Because there is already a tuberculous organisms roaming around, and they find it easy to settle at one point. But that should not have taken for such a long time. Okay, now TB can just fool us with varieties of ways, but we are just looking at, did he have something already brewing up and the trauma just facilitated to localize it? And therefore we'll keep both the issues in mind. Slowly coming up infection in a child who was already tuberculized, already infected, but not manifesting a disease, or there must have been a prior mild defect in the bone or a spinal cord that worsened after trauma, to which I feel it should have happened quickly rather than over time. And then of course the mass that we said slowly growing, and mass could be tuberculous as well. So we keep it open at that time.
And sir, this breathing difficulty and a seizure, you think it is?
No, I think you are right. You must have seen many children coming with acute breathlessness, acute bronchiolitis, acute asthma, acute pneumonia. Which one of them had a seizure? While it is possible, okay, most of them would not have a seizure. They would probably get unconscious. They would get an encephalopathy. Unlikely all that. Because a respiratory failure may manifest CNS symptoms, but not respiratory dysfunction. Two things are different. And therefore, this, as you said rightly, it must be related to a spread of the disease. And what is funny is, he's 12-year-old. So 12-year-old spreading to CNS TB should not manifest suddenly with a seizure or unconsciousness, etc. But this must be going on for a long time, and therefore there could be of any kind. When we have seen a pulmonary TB at this age becoming CNS TB, okay, only when the host is cerebrally abnormal, severely malnourished, or you have a resistant TB, child is already on treatment for 3 months, few drugs are working, others are not working, and now the spread all over. So the combination of this is unusual in this child.
Okay. Nothing special in the negative history, right? Okay. So come now, tell us your provisional diagnosis at the
What
end.
is that ulcer over the back of the head?
So because he was like bedridden.
This 12-year boy, birth and developmentally normal, immunized up to date, brought with history of chronic intermittent neck pain since 3 years, which progressively worsened since last 2 months, and associated with rapidly progressive weakness of the limbs, which was asymmetric, left more than right, started from the left upper limb, progressed to involve both lower limbs and right upper limb, and further progressed to involve bladder in the form of straining and frequency, and then respiratory weakness associated with 1 episode of hypoxic seizure requiring mechanical ventilation, which could be due to diaphragmatic palsy, with no history suggestive of cortical, subcortical or cranial nerve involvement with intact sensations, and no history of autonomic dysfunction, with history of shock-like sensation in the left upper limb suggestive of radicular pain, possibly extramedullary compressive lesion of the cervical cord. DDs could be cervical TB with compressive myelopathy or extramedullary cervical space occupying lesion.
So how do you differentiate extramedullary from intramedullary clinically?
Extramedullary, the weakness will be early, and intramedullary, the sensory loss will be early. And in extramedullary, the bladder involvement will be the last thing, and in intramedullary, bladder involvement will be early, and radicular pain in extramedullary.
Okay. Go on.
General examination, child was examined in supine position with ET tube and RT in situ, with IV cannula on the left hand and Foley's in situ. Child was conscious, making good eye contact and following commands to the best of his abilities. He's moderately built and nourished. Vitals, heart rate 100 per minute, respiratory rate 24 per minute on ventilator. Temperature 98.7 Fahrenheit. CRT less than 3 seconds, central and peripheral pulses well felt, normal volume, blood pressure 110 by 70 millimeter Hg measured in the right upper limb, no pallor, edema, icterus, clubbing, lymphadenopathy. Anthropometry was normal. Head to toe examination, there was 2 into 2 into 1 centimeter single ulcer present over the occiput with well demarcated margins with serous discharge. Eyes, ears normal, RT and ET in situ. Neck was stabilized by the cervical collar. The other things were normal. No spine was normal, no deformities or contractures. Systemic examination, CNS, higher functions. Child is conscious and alert and following commands to the best of his abilities. Attention, memory could not be tested. Speech and language could not be tested. Cranial nerves, first cranial nerve not tested, second cranial nerve, gross vision, child is fixing at and following objects and people. Pupillary reflex, pupils reactive to light, Meniere's reflex, blinking of eye present when finger taken close to the eye. Fundus normal, third, fourth, sixth, extraocular muscle movement function is intact, no squint or ptosis. Direct and consensual light reflex is present and accommodation reflex present. Sensations present over the face, conjunctival reflex present, no asymmetry of face, deviation of angle of mouth, child is able to close his eyes tightly, wrinkling of forehead is present, conjunctival reflex present, eighth cranial nerve able to understand and follow verbal commands.
One sec. What is Meniere's reflex?
So we bring a finger close to the eye suddenly and there is a, blink.
What is your aim in doing a Meniere's reflex?
To see the vision.
So if a child is already fixing and following objects, then would you do a Meniere's reflex?
No, sir.
So Meniere's reflex is usually done in a child who's altered sensorium or who is not apparently focusing or fixing. So then you want to see whether there is some evidence that he can see, and that is when you do that, right? Similarly, would you do doll's eye in a conscious child?
No.
Why not? It will be normal, no? Why not do it in a conscious child? It will be normal.
They can willingly fix their pupils in the direction which they want, so we can't get the results we want.
Very good. So what is doll's eye a test of? What is it testing?
Brainstem.
Brainstem function. So it is only when the cortex is cut off and brainstem has taken over that you want to know whether the brainstem is intact or no. When the cortex is intact, it will rule over the brainstem. So there will be volitional control, as he said, right?
Gag reflex present. He's not able to shrug his shoulders. 12th cranial nerve not tested. Motor system examination. Posture, child is lying in supine position with both arms adducted and internally rotated at shoulders, both forearms pronated and slightly flexed at the elbow and hands adducted and palmar flexed at the wrist, and both legs extended at hips and knees. Bulk of the muscles appears to be normal, no atrophy or hypertrophy. Tone is decreased in both upper limbs and increased in both the lower limbs. Power, shoulder abduction, adduction, right side 2/5, left side 0/5. Elbow flexion extension, right side 1/5, left side 0/5. Wrist flexion extension 1/5 on the right side, 0/5 on the left side. Hip flexion extension 2/5 on the right, 0/5 on the left. Knee flexion extension 2/5 on the right and 0/5 on the left. Ankle plantar dorsiflexors and plantar flexors and dorsiflexors 2/5 on the right, 0/5 on left. Reflexes, DTRs, all DTRs are brisk, and there is ankle clonus present. Right side it is ill sustained and left side it's well sustained. Superficial reflexes, plantar reflex, bilateral extensor, abdominal reflex absent. Sensory system examination, touch and pain sensations were intact, like how much ever we could test. Cerebellar signs, no nystagmus, other signs could not be tested. Other systems are within the normal limit. Summary, 12-year-old boy with chronic intermittent neck pain with progressive worsening since 2 months, associated with gradually progressive weakness of limbs starting from left upper limb and progressively involving other limbs, which is asymmetric in nature, confirmed on examination with presence of upper motor neuron signs with respiratory weakness requiring mechanical ventilation, possibly due to the affection of the phrenic nerve, C3, C4, C5, and difficulty in shrugging of shoulders, and bladder involvement requiring catheterization with intact sensations with pressure sore over occiput, possibly extramedullary compressive lesion of high cervical spinal cord. To rule out cervical TB, extramedullary cervical space occupying lesion.
Okay, so now between these two possible etiologies, cervical TB and SOL, how would you debate?
So for like TB, it's too longer duration, like 3 years. If we consider 3 years, then it's like not.
So that long duration is going against TB, then?
And he's well nourished, like that.
Okay. Okay. Just one small point in your summary after that, possibly due to affection of phrenic nerve, difficulty in shrugging of shoulders is not the cause of mechanical ventilation. So you say as evident by. So means difficulty in shrugging of shoulders tells you that there is a possible lesion at C4 which explains why he possibly failed breathing and needed mechanical ventilation. Okay, so a little bit of change of wording.
How will be the pattern of breathing when phrenic is gone, diaphragmatic is gone?
So, seesaw breathing.
What be?
Seesaw breathing.
Means what?
Like usually when we inspire, the chest is more prominent than, chest muscles are more prominent than the abdominal muscles. So it is vice versa when there is diaphragmatic.
Then what will happen if intercostals are gone? If intercostals are gone, the diaphragm is working. And therefore when the diaphragm descends, the chest will collapse and the abdomen will come up, which is seesaw breathing. And when diaphragm is gone, when it takes a deep breath, abdomen just doesn't come up. So in diaphragmatic breathing, abdomen remains scaphoid. While in intercostal breathing, you get a seesaw. So here what you will see is diaphragm is gone. He takes a deep breath, the abdomen just doesn't come up. And diaphragmatic breathing contributes to as much as 70 to 80% of breathing. So when somebody is breathing and if the abdomen fails to rise, abdomen, that means the diaphragm is weak, and be ready for quick intubation as against intercostals.
Okay, now how will we investigate this child at this stage? What all do you want to do?
General and specific investigations. General examination, general investigation, CBC, if there's any infectious infection, we can...
Speak louder and list all the investigation, then we'll see.
CBC, ESR, uh, want to a chest X-ray, general examination, general investigation. Specific, we want a MRI, imaging, MRI of the spinal cord, and maybe the brain also for the hypoxic episode.
Anything else anyone wants to suggest? Okay. So tell us what investigations.
So this was the MRI done in the outside hospital, which showed it showed space occupying lesion in the cervical region, highly suggestive of infective, most likely tuberculosis rather than neoplastic spondylodiscitis involving C3 to C5 vertebrae associated with anterior epidural and left paravertebral soft tissue. Then these were also the investigations done in the outside hospital. CT chest, abdomen and pelvis showed few pre and paratracheal hilar and infrahilar lymph nodes with the largest measuring 1.6 into 1 centimeter. They did a cervical lymph node biopsy. Gene expert and AFB did not show mycobacterium, and cervical lymph node biopsy histopathology showed ill-formed epithelioid granulomas with central caseation. Query Cox etiology, and CBNAT of the, after the surgery, the CBNAT of the epidural tissue, the TB workup was negative, and histopathology gene expert was negative, and histopathology showed paucicellular smear with occasional aggregate of epithelioid histiocytes, suspicious but not diagnostic of Cox. These were the investigations done in our hospital. The total leukocyte count was elevated with the neutrophilic leukocytosis. The other baseline investigations were normal, and this was, we repeated the MRI in our hospital, which showed post-op changes extending from C3 to C5 levels, irregular anterior epidural soft tissue from C2 to C5 level in the cervical spine with local extension and associated cord compression, focal and ill-defined irregular soft tissue along the scalene triangle region on the left side of the neck. Possibility of neoplastic etiology, round cell tumor appears more likely than infective etiology. So he was taken, he was taken for surgery, and C3 corpectomy with anterior and posterior spinal fusion was done. We also sent gene expert and AFB of the epidural tissue, did not detect MTB. The culture sensitivity has showed CRE Klebsiella, and frozen section is showing malignant round cell tumor. Histopath and IHC report are awaited.
I think when we considered both these possibilities, even at the end of the story, we are almost there. So looks like maybe more likely a tumor than the tuberculosis. My questions are threefold. One is that it has taken few years to develop, from mild pain for 2-3 years, and then the severity. So the question is, was the first 2-3 years of pain was psychogenic, and then came the pathological pain, or whether the story was slowly growing to an extent that it took several years to manifest. Both are likely, but we would not have called it psychogenic for no reason. That's number one. Second is, if this is tuberculosis, is it primary or secondary? I'll ask you a more simple question. When I have a tuberculous cervical lymphadenopathy, is it primary or secondary?
Secondary.
Secondary to what?
The primary complex.
I have no symptoms. I have only symptom of lymph node. Okay, it's slowly going up. I'm not eating too well. Confirmed TB lymphadenitis. Don't you think it's the primary? So where is the primary?
Lungs, in the lung.
So it is a primary complex. Okay. And therefore the primary is in the draining area somewhere. Maybe tonsil. Okay, not seen. Like a primary complex in the lungs, you see only the hilar. Okay, you don't see a primary infective focus in the lung, nor you see any lymphatics which are infected, but you only see the lymph node. So now my question is cervical vertebral TB primary or secondary?
Second.
Because we have no focus anywhere else. Is it because of some draining area? In other words, there must have been an active focus somewhere, commonly in the lungs, not picked up, and it has disseminated. Then my next question is, this child is healthy, is getting adequate nourishment. Okay. Would a healthy child have a dissemination from primary into the bone? Unusual. So it could happen with injury and that could facilitate. Okay. Next question is, can TB be silent or took few years to develop? Yes. Could it be atypical mycobacteria? What is the classical manifestation of atypical mycobacteria? Localized lesion, chronic, years. And TB lymphadenopathy could mimic Hodgkin's. Of course, both can be together as well, but one can mimic the other, which means it can go on for a long time. Do you think it's an atypical mycobacteria?
That is more likely an immunocompromised host.
Nowadays we see it in all lab reports and also after tattooing. So you need not be immunocompromised to get it. And from the oral cavity you can get an atypical in the neck itself.
So just a thought for discussion. Okay, I'm sure almost we have hardly seen an atypical mycobacterial more than a lymph node which is chronically inflamed, sometimes draining but not getting better, and then you pick up an atypical mycobacterium. But just the thought that it is one of the tuberculous disease which goes on for a long time and has a very characteristic feature of localization and no dissemination. Localized destruction. Okay. Just a thought. I have no knowledge. I have not seen one doing like that. I have seen a lymph node doing like that. Okay. So just a thought for that. Anyway, I think the point is, this is a good example that so many investigations could not say, finally said what we said to begin with only. That is the power of clinical analysis. Okay. And at times you may not pick up something and you stay there only. And therefore, this is where it is.
That last line is scary. The culture with a carbapenemase resistant organism requiring ceftazidime, avibactam and astriona. The last resort. This child must have received multiple courses of antibiotics.
Again, I feel if you have a very, very potent bacteriology department, they would find the organism everywhere. Okay. Because of our fault. Okay. Because, see, now we are thinking about years of slowly growing tumor, but we pick up an organism. Maybe we introduced it while doing all that. That's possible.
One has seen a tuberculous lymph node and then spreading over here, going on for 9 months in a 2-year-old child. And the biopsy showed that AFP, the lymph node was teeming with AFP. Now that almost never happens with a typical bacteria. This was atypical bacteria. The pathologist very immediately remarked that when I see lymph nodes teeming with tuberculous bacilli, it cannot be typical. And it was an BCG introduced tuberculosis which spread in a child who had BCG 3-4 months back and then went on spreading. So if you see too many bacteria, when you don't expect too many, think of atypical. Another thing to be noted here is, this is a good example of studying a spinal cord compression syndrome. Left upper limb followed by left lower limb followed by right upper limb is a classical cyclic situation and compression pathology extradural. So please try to go and read again that how would it will manifest, and you must always try to find out in a compressing pathology where is the lower motor neuron type. If there's a, you have given everything upper motor neuron, was there anything lower motor neuron type there also? It may have been there, or it may have been, if it is not related to any reflex, then you will not be able to see that. So it's a good case to study external compression of spinal cord. This is, the sequence is quite classic.
Just one or two things and then. So you said gene expert was negative initially, right? So isn't that ruling out tuberculosis? What is the interpretation if gene expert is negative? Any sample, if gene expert is negative, what is the interpretation? We're just revising our basic understanding of the diagnostics, no? So what does gene expert pick up?
Bacillary load was low, so it could not detect. But if clinical suspicion is high, we can still consider. Like.
Yeah. So first is that gene expert has a level, so many number of bacilli per ml or whatever, below which it will not pick up. That level comes down further with gene expert ultra, right? Which is I think 11 bacilli. But even if suppose there are only 5, then it will still not pick up. So that's the first concept. So that is why when you are suspecting, you always have to send for culture. If gene expert is negative, how will culture help?
It will let the bacteria grow.
Yeah. So even if there are few bacteria, they can still grow. So at the end of that culture, you can still get a growth. So that is one. Second, does gene expert pick up dead or live bacilli?
Both.
It picks up both. So therefore, we don't know whether they are live or dead, but it picks up both. So that is why culture always has to be done, right? So that is one. Second, she mentioned somewhere that other workup for COX was negative. So suppose first your gene expert was negative. Sir asked, is this primary? So bony tuberculosis is always secondary. You disseminate or you hematogenously spread the bacteria to a bone from somewhere, right? They don't first go there. So where will you look for the primary and how?
Chest X-ray to look for any primary. GL or a sputum.
Chest X-ray of course, but then again the lesion may not show. So to complete your studies, you will have to do induced sputum or gastric lavage, whatever, and show that you are not getting AFB. So primary is always in the lung and you have to search for that.
Just one question related to that. Would you not do a blood culture? Most important, right? Are you sure? Have you done blood culture for TB? Why not? You say typhoid, you say infection, for blood culture is must, but not for TB. After all, the organisms spread through the bloodstream, no? Pick them up there. They are all roaming there. The lung lesion may be very small. Blood culture should be done. Why should we never do blood culture? That's the question. Give a thought.
They are present in the macrophage, so no.
So there is hardly any significant stage of bacteremia. Okay. And therefore, they are not roaming all the time in the bloodstream. They are just in transit. Whereas when you see a salmonella, there is a bacteremic stage. Okay. In fact, much before they settle in the Peyer's patches in the intestine, you have a bacteremic stage. Therefore, for TB, never a blood culture at all.
This is just an appreciation, Namrata. Your summaries A sentence has 92 words in one sentence.
So one question.
Yeah.
So could this? Why was no sensory? Why was there no sensory involvement in such a child with so many left upper limb, right upper limb? There was no intact. There was intact sensation.
So you found all sensations normal?
Assessed properly because he was.
My thinking would be that it may not be very easy to perfectly assess and be dogmatic that everything is normal. There must have been something affected, right? Okay. If it was TB, how would you have treated him?
Since he's having this compressive symptoms, first it has to be decompressed and then AKT along with steroids for the cord compression. 0.15 kg, 0.15 mg per kg, 6 hourly dexamethasone for 6 weeks and to be tapered.
How will the steroid help?
It will reduce the edema, sir.
Indications of steroids are very few in TB, and the classical examples are when the manifestations are immune mediated. TBM classically, okay, to some extent pericardial disease, but not pleural. Okay, why not pleural? I said specifically not pleural, but pericardial, yes. Both are pathogenesis same, both are small lesion somewhere and an inflammatory exudate mediated by an immune mechanism. Why not pleural? Give a thought, doesn't matter. Okay.
Pericardial area, probably a smaller space, more symptomatically worse if the patient has got a pericardial effusion and a pleural effusion.
Because the organization post-inflammation will result in constructive pericarditis, which will result in more acute life-threatening event rather than a pleural cavity and a pleural cavity inflammation of TB. So TB constructive pericarditis is much more life-threatening. So that's why we need to cut off the inflammation as soon as we can.
You give steroids only to prevent complications. So in a TB meningitis, you have an encephalopathy, which is immune mediated, that's likely to kill the child. So we are worried. In a pericardial effusion, we are worried for a complication which may persist and cause a cardiac problems, like a constrictive pericarditis. Would you not get the same in a pleura? Possibly not. The reasons are twofold. Diagnosis is much easier in a pleural effusion. In a healthy child, large fluid of very small duration. And in a malnourished child, extremely small effusion of a long duration. Both do not have complications. If you have a healthy child, he comes to you with a tuberculous pleural effusion even in 12 hours of onset. Massive effusion and breathlessness. If he is undernourished, he can't throw up immune response. He may not even manifest with pleural effusion. It is only on investigation that you pick up some fluid, and therefore the complications are much less likely, and therefore steroids are used only there. And only one other indication of steroid in tuberculosis theoretically is endobronchial tuberculosis. I haven't seen much, okay, but people who do a bronchoscopy now can pick up even an endobronchial tuberculosis much before it gets onto a lung, etc. But that's one more, again because the complications are more likely. But if you have a TB lymph node, you are not worried.
So what about VQ mismatch? Suppose you have miliary with a VQ mismatch, steroids.
And therefore, another what would be a TB spine, okay, And especially in a TB spine, you could have an acute spinal vasculitis. You have a bone TB, okay, you are getting some tenderness over. If you ignore it, and if you are unlucky, you may get an acute spinal vasculitis and a paraplegia. So that risk is there. Again, that's immune mediated, and therefore steroids would be right. Absolutely.
In a miliary we use steroid. Why do we use miliary? Is actually spread TB, and yet you are using steroid. So what is this logic? You are allowing it to spread more. What is the logic of using steroid in miliary?
You use steroids in HIV? It's immunosuppression. Miliary is also immunosuppression. The point is, even immunosuppressive disease have other components of immune inflammation. Okay, Burkitt's lymphoma is a manifestation of a chronic HIV. Okay, tumor. So to that extent, miliary, what is typically a miliary? Look at the example of HIV. CD4 has gone down, CD8 might have gone up. One lymphocytic population has gone up, you suppress it so that the balance is maintained even when you have a low CD4. That's the reason why in a miliary, not everybody gives it, but I feel it's logical to give it. Only for a short time, maybe 2 to 4 weeks, and maybe even 1 milligram per kilogram, not even 2, but that is more likely. And in TBM, you will always give it. How long would you give it?
2 mg per kg per day for 4 weeks and tapering over 4 weeks.
You would generally, epidemiological evidence says, give it for 6 to 8 weeks and then taper it off. But when you taper it off and he starts getting similar symptoms again, you may have to continue steroids. Of course, you will have to be very careful whether it's a resistant TB. So occasionally, a steroid may be required for months in an anti-TB treatment.
Fine. Any questions here on this, or we move to the second case for today? Okay, yeah.
Did we get any explanation for the convulsion?
Like there was no hypoxic damage as such, like because the sensorium also was good post intubation.
So we've not got an explanation for the seizure.
I think all that could have happened to my mind is that after all this child is not breathing well. Okay, there could have been some mucus plug somewhere suddenly obstructing in the major airway. Okay, and then caused a sudden hypoxia. Maybe that's the possibility, but we are not sure what it is. And it's unlikely to have caused a significant damage to the cortex.
Okay, so we'll have the second case for today, and that is being presented by Yashodan. Yeah. You want to connect your laptop? Yashodan is from Sion Hospital here.
नहीं कुछ नहीं Good evening, everyone. My name is Yashodhan. I'll be presenting a short case for today. So my case is a 1 year, 1 month old male child. He is third by birth order. He is born of third degree consanguineous marriage. He is hailing from Razade, Nandurbar. He is Dhangar, tribal by community. He is Hindu by religion. Informant being brother, who is reliable. Informant big brother, who is reliable, and he is referred from Civil Hospital, Surat. So he has come to us with chief complaints of fever for 10 to 12 days. It was mild, undocumented fever, which was intermittent and subsiding on oral medications to recur again. This was associated with cough and cold in form of runny nose and cough in form of dry, mild, intermittent cough, which was non-spasmodic. It was also associated with 2 to 3 episodes of post-tussive vomiting, small quantity, non-bilious, containing food particles. So upon this, some symptomatic management was given, and on 23rd of October, so these complaints went on for a week, and then on 23rd of October, the child was taken to a local hospital where he was admitted and given IV medications. Upon investigations, the parents were told that the child will require blood transfusion, and 1 PRBC transfusion was given to the child. And during the hospital stay, the mother noticed abdominal distension, which was generalized abdominal distension, and which was soft and non-tender on touch. On 25th of October, for further treatment, child was referred to Surat, and on 28th of October, the child was referred to Sion Hospital in view of further management. With the above chief complaints of fever for 2 weeks, around 10 to 12 days, and abdominal distension, there was no complaints of increased work of breathing, chills, rigor, or any rash. There was no complaints of abdominal pain, vomiting, jaundice, constipation, or lethargy. There was no complaints of bleeding manifestations or any swelling over the body. There were no complaints of persistent cough for more than 2 weeks or COX contact. There was no history of fever with rash in mother during pregnancy. So past history, he was admitted at 6 months of age for cough and cold, and he was given some IV medications. He was admitted for 3 days. No oxygen support was required, and then he was discharged. Birth history is significant. He's full-term normal vaginal delivery. He's delivered at home, and the cord was cut by a sickle, so unsterile. He cried immediately after birth, according to the mother, and the birth weight is not known. Birth vaccines are not received. The mother did not breastfeed the child because she had lactational failure. She had no breast milk. And at the time of birth, they had noticed silvery white hair, eyebrows, and eyelashes in this child. But they did not seek any medical care at that time. They thought it is normal. And so he's unimmunized. Developmentally, he has features of developmental delay in all 4 domains. Gross motor wise, he sits with support. Fine motor, he has immature pincer grasp. Language, his bisyllables. He has social smile and has not developed stranger anxiety even after being 13 months old. Dietary history wise, he was not breastfed, started on cow's milk since birth, and currently he takes cow's milk with biscuits, and bottle feeding is present, and the diet is deficient in calories and proteins. Family history, there is no family history of similar complaints in the family, no family history of any blood transfusions. And socioeconomic history wise, they belong to the lower socioeconomic strata, Kupuswami grade 5. So,
okay. You can, okay, so what are your thoughts on this initial complaints? What would you have thought? Come on, anyone. Let's speak so that we learn.
Sir, simple bronchopneumonia. Maybe child was given some nebulization, followed by he developed abdodistension.
Okay, so we'll have to discuss all the words. So why simple bronchopneumonia? So what is complicated bronchopneumonia?
I mean bacterial.
So first of all, what is bronchopneumonia? Is it a simple disease or it's a a serious disease?
Serious disease.
Is there a term called bronchopneumonia being used now? We use it in practice, we use it day in and day out, but is it technically correct? So in short, basically bronchopneumonia means you are talking of bilateral extensive involvement in the lungs. So this has to be a tachypnic child and who's sick. This picture, does it look like a sick child to you? You're saying mild fever which is undocumented, intermittent subsiding, cold and cough, runny nose, intermittent non-spasmodic cough. So overall it looks like a very mild non-specific illness, right? So the only odd point is, why is it going on for 8-10 days? That's the only thing that crosses your mind. Otherwise it looks like a very non-specific illness, right? And then you said that this child was admitted for this.
So he was taken to a local hospital, then he was admitted, IV medications were given, and on investigations they were told that the blood transfusion is
We'll
needed.
come to investigations later. So why did he need admission? Means if I am taking the history, I would ask the parent that what precipitated the admission? Did he become breathless? Did his fever worsen? Was he sick? What was the reason? Why would he need admission?
There was persistent fever, which was not subsided.
Yeah, but you said it was not very...
intermittent fever lasting for more than 7 days. So that's why he was admitted. That was the indication.
Okay. Now, after investigations, they were told that he needs a blood transfusion. So what is your thought process on this statement?
I would like to know first the course from the birth to the current history, right? Like what is the condition of nutrition? Is he malnourished, or is there any other complaints which might be related to the current condition? Because with normal course, the anemia can be explained in the normal child if the feeding and nourishment would be normal.
He gave us the history that this child was on milk, cow's milk and biscuits. So did you expect anemia or you don't expect anemia? Which anemia? So what would they have found on investigation? And so they gave blood. So come on, your thoughts on this. What would you think? So that anemia is a chronic anemia or acute anemia? Chronic anemia. So he should have been compensated or in failure. So if he was compensated, so all this we could have got from history, whether he was very breathless, whether he became worse, etc. But mostly not. So my guess is almost that it was a chronic anemia, well compensated, but they must have got panicky looking at the number 3 or 4 of hemoglobin and they may have transfused, I don't know. So that is my thought process.
I think if moment you said that this host is likely to be undernourished, we want to know whether he has a kind of a calorie protein malnutrition or he's getting enough calories but not iron, etc. That's important. And you would have easily picked up. Was he breastfed for first 6 months, continued breastfeeding, complementary feeds? If nothing of that kind happened, then this child is a PEM. And I think this is what Hemant Joshi has circulated just now. And he says, first question is, was the child completely all right prior to first symptom? Okay. Just now he spread it, distributed to all of us. How important that is. Your story should start from there. Then we know straight off that what looks like a very ordinary simple viral infection is behaving not so simply. So is the virus not simple? Looks simple? So the host is not simple. You get straight above there. Now, what is wrong with the host? That's what we want to know. Is it primary malnutrition, or he has some disease which is making him malnourished? Now tell us, what is the likelihood between the two? You get my question? I feel this is a cystic fibrosis, malnourished child, respiratory infection, needing hospitalization, CF, immune deficiency.
Sir,
Or you think primary nutritional deficiency? Make a guesswork.
Sir, in case of primary immunodeficiency, if we are suspecting, there should be the history of multiple admission along with long stays and higher antibiotics.
2 episodes are there in the first year. How many more do you want? More than one is multiple. You're right, but I'm just going to put a break on your thinking. Think further. You're right.
Then, sir, overall growth may be affected in the. But in PID, there would be more affection of growth and weight as compared to.
Would you differentiate between the two? Give a thought.
So with the given dietary history and the background, like he was never given breast milk and was on animal milk from the beginning, and weaning was not done properly, so looks more like nutritional. And for cystic fibrosis, there's no recurrent respiratory infections or malabsorption. Like, we don't have that history.
I want to make a statement. All bottle-fed babies are well nourished, constipated and anemic. Why should a baby who is on cow's milk, who is being adequately fed, drinking 1 liter of cow's milk per day, should be malnourished at all? Which bottle-fed babies you have seen malnourished? All chubby, anemic. So bottle feeding is not the cause of malnutrition unless the feeding is improperly diluted. 1 part of milk and 5 parts of whatever it is. Okay, so that's not, in fact, I would say the baby was reasonably nourished. As far as protein calories are concerned, if you include anemia as a part of malnutrition, which it is, then they're malnourished. Because cow's milk does not give iron, but it actually produces loss of blood because of allergic gastroenteritis, so to say, and there is a chronic loss of blood. So they are first candidate to get iron. This child was iron deficient. Maybe he may have been 5-6 grams. Maybe they thought that it was necessary. But just because he was bottle fed does not mean that he was malnourished. He may have been better nourished, unless he was on a dilute formula.
So as a principle, what sir was trying to say is that you have a primary big disease which causes malnutrition. What would be the story? Initially normal baby, normal first whatever period, 1 month, 2 months, 1.5 months, 3 months, whatever. Then big manifestations of the primary disease, and as time passes, this child becomes undernourished. Whereas primary nutritional is undernourished right from early, and these diseases come as a secondary effect a little later in the story, right? So that's the conceptual difference which you'll have to try and fish out from the history, right?
I think typically primary malnutrition because of deficient intake is a child who wants to feed more. His appetite is more. Because it's not satisfied. And the mother would say, "Bar bar mangta hai." And if it is secondary, she would say, "Pita nahi hai." What simple way to differentiate the two? Onset, yes. But for example, onset of a T-cell deficiency could be right at 6 weeks, 8 weeks. Okay. If the onset is later, it could be immune deficiency, B-cell. But the more important is pathological malnutrition or secondary malnutrition as a loss of appetite, And primary malnutrition has a good appetite, with one exception. Which malnutrition has a loss of appetite? I just said primary PEM has a good appetite, wants more, but is not getting, with one exception. Severe protein malnutrition, kwashiorkor. He is lethargic, no. Do you see kwashiorkor nowadays? Our government has done very well. No protein deficiency. Then why? I know you have not seen kwashiorkor. Maybe we have seen kwashiorkor. Yes, sugar baby kwashiorkor. In a healthy baby competition, he would be the first prize because he was having edema and good weight. Why don't you see kwashiorkor today? If you tell our CM, he will say, because I have improved the nourishment of all that. Anybody will say that. And the reason is, when I was being trained, children were getting enough calories but not proteins. And now they are not getting either of the two. Therefore, the protein requirement has gone down because the calories are gone down. You need 8 to 10% of calories coming from proteins. You don't have enough calories, you don't need much protein. So now you get PEM and not kwashiorkor. Yes? So we have deteriorated.
All our current kwashiorkors are marasmic kwashiorkors. They have protein and calorie deficiency. They don't gain weight. And bad infection produces an edema. You treat the infection, the edema goes, the child remains marasmic. So he is PEM with edema. And then he is recovered, so he is PEM without edema. But PEM basically. So marasmic kwashiorkor and marasmus, they don't improve. That sugar patient kwashiorkor, we now not see. Those babies were described in the beginning in Africa, where the baby was suddenly weaned from mother's milk. Kwashiorkor, kwashi, disease of the second one due to, first one due to arrival of the second one. So one was suddenly weaned. So these babies got real good calories, but they didn't get enough protein. That is almost same. So we have always malnutrition. PEM, as Dr. Udani said, EPM, more than PEM. That means not protein energy, but energy protein malnutrition. Caloric basically. Then the proteins are utilized for wrong purpose, for generation, because that's a priority. And therefore, secondarily, proteins are not available for the work that they are supposed to do, that is growth and development. So we have only PEM, sometimes associated with edema, and you treat and the edema goes, but he never improves.
Now we'll examine this baby, so we can, you have that cot and sheet. Just call the baby.
Non-spasmodic cough fellows are less likely to have post-acid vomiting.
So 2 people to come and observe and tell us your findings. Come, volunteers. One more to help.
without, if you start touching, he'll start crying.
So the child looks very pale with golden color of hair. Hair is without luster. Child is very thin and cachexic.
The child looks irritable but doesn't look very thin, not cachexic.
Okay, so you want to say that he is thin but not cachexic. Okay, then what else? Irritable. Then any dysmorphic features?
No dysmorphic.
No
features.
dysmorphic features. So what is happening now?
Responding to
Very
any
good. So
stimulus.
responding very well to any environmental stimuli. Then does he have any edema?
What's his growth like? And what's his nutrition like? He's a year and 1 month. So just guess whether his length looks okay, whether his weight looks okay, whether his head circumference looks okay, from a distance. 1 year, 1 month.
No, sir. For 1 year of age, his growth is less.
What was his weight? Yes.
His weight could be
Yeah,
around
10 kg.
around 7 to 8 kg.
He certainly looks small in weight, even small in length. Head circumference looks all right. What's his nutrition like? Does he have, from a distance, a protein deficiency signs? Anybody, you're seeing from a distance, good enough. Protein deficiency signs from a distance.
No, sir, no protein deficiency.
So what are the signs you are looking for of protein deficiency?
Edema, which does have.
So one is edema, then
Skin fold thickness. If there is any thickness of skin.
thickness of skin, that you wouldn't know. What else? What are the pure, means big signs of protein deficiency?
What are signs of protein deficiency?
Hair with no. Yeah, the hair has no luster and.
So in
easily
fact
plucked.
he has a lot of hair. It does not sparse hair. And luster, he mentioned something about discolored hair being there right from birth.
Yes.
He said that in his history. Okay. What other signs?
Apathy. He is responsible.
Apathy. So apathy and edema. These are your two big signs of protein deficiency. So is he apathetic? He is not apathetic. And edema also grossly you couldn't see, right?
See, typically apathetic and disturbed becomes irritable. When I was trying to do something, he was keeping quiet. He was interested in something around. So there is no protein deficiency. And one more finding of protein deficiency is the bulk of a muscle. Did not look too bad. Obviously the color is not protein deficiency that he is born with. Okay. But he is certainly irritable, possibly because he has seen all of us. Okay. Because he was quiet there. And therefore, that is what we... Anyway, he is crying, so let's look at this.
Quickly examine 1 minute. Come.
Okay. अभी 1 minute इधर सुला.
Go, one of you quickly go and examine whatever you...
A quick abdominal examination. Quick abdominal examination.
छोड़ दे. बाद में बात.
Sir, the hair changes. The hair changes. Color. When do you get hair color changes? What is the cause for the color changes? Forget the birth. if at all you find it in a PM, what are the causes for changes in color? So it's usually copper, selenium, zinc. And if it is from birth and repeated infections, he spoke about silvery hair. Shediac Higashi and Griseli. Right? Anything else to the list? Hermansky Pundalak is a variant of Shediac Higashi itself.
What are signs of protein deficiency in a nephrotic syndrome? Severe protein deficiency, more than PM. Baldness, no hair, all plucked. Severe edema. Okay. Massive edema. So one symptom of nephrotic hypoproteinemia is a massive edema. Not so much massive in PM. Must be hair changes, mental changes and skin changes must be extreme. Logic demands, no? More the protein deficiency, more kwashiorkor. Massive edema, but no hair changes, no skin changes, no mental changes. In fact, happy soul. What kind of protein deficiency it is?
So, sir, in case of nephrotic syndrome, while the intake and all is not affected, but the only specifically albumin is lost.
Very good. Then what are the changes due to? But protein deficiency, no?
But sir, other nutrients will get.
There is no other nutrition in the nephrotic syndrome. There is no loss of other nutrients in the nephrotic syndrome, whereas in the protein energy malnutrition there is a macronutrient deficiency which leads to hair loss.
So the skin, mental changes, hair changes are due to amino acid deficiency and not protein deficiency. And what he said, the proteins are, intake is fine, absorbed, amino acids are found, but they are being lost. So those are the signs of amino acid deficiency. When you don't have proteins at all, you don't have amino acids also.
They are available in the nutrition. They are available, synthesized, circulated and lost. In malnutrition they are not available. The question of synthesizing does not come. That's the
If you have not studied and you have failed, okay, another instance is you have studied but not assimilated, therefore failed. Both are failed, no? Manifestations are same, but here different because that has gone through process, whereas when we have not studied or studied but forgotten, there is no further process at all.
They studied a lot, could not write the paper. Out of 10, only one question was written, so they failed. Too much of knowledge, perhaps.
Okay, so now tell us your findings.
How much must be the weight?
7.2 kg. 1 year, 1
Go on.
month. So on general examination, baby is afebrile and active, vitally stable with heart rate of 110, respiratory rate of 30 per minute, saturation of 100% on room air, BP of 86 by 40 millimeters of mercury. For him it is between 58 to 90th centile. Extremities were warm and peripheral pulses well felt. There was pallor present, but no icterus, no cyanosis, clubbing, edema and lymphadenopathy. Coming to the anthropometry, he fits, for the weight criteria, he fits between -3 to -2 standard deviation, weight being 7.2 kg. Length is 70.2 centimeters, again -3 to -2 standard deviation. Head circumference is 43.5 centimeters, -3 to -2. Mid upper arm circumference 12 centimeters, -3 to -2 standard deviation. So impression by anthropometry is moderate acute malnutrition. So on head to toe examination, the anterior fontanelle is closed, hair, silvery white hair which are easily pluckable, and there is hyperpigmentation which is peculiarly seen on sun exposed area. So his face has His face was hyperpigmented, but his chest and trunk were they were not hyperpigmented, basically hypopigmented. There were silvery white eyebrows and eyelashes. There was wrist widening, and hypopigmented macules were present on the back and nape of the neck. There was no bleeding manifestations such as ecchymosis. So that was my, so this is the general head-to-toe examination. Coming to the systemic examination, because the primary complaints were of involved abdominal distension. So per abdomen, on inspection it is distended, umbilicus was central and everted. It is generalized hyperpigmentation was also present. Palpation, on palpation the abdomen is soft and non-tender. Liver is palpable, non-tender. It is 5 centimeters below the right subcostal margin and in the mid-clavicular line. The span of the liver is 11 centimeters. On palpation it is firm, the surface is firm with rounded margins, firm in consistency with smooth surface and rounded margins. Spleen also is palpable and non-tender. It is palpable just beyond the umbilicus. So according to Hackett's classification, grade 4 splenomegaly, it is 9 centimeters below the left subcostal margin and firm in consistency and smooth surface. On percussion, there was tympanic note in flanks and in hypogastrium, otherwise dull note over the organomegaly. On auscultation, bowel sounds were heard normally. Rest of the examination was within normal limits. Respiratory being air entry was bilaterally equal and clear. CVS, both the heart sounds were heard normally and no murmur. In CNS examination, tone, power and reflexes were within normal limits. So my provisional impression for this child is, he's a 1 year 1 month old male child, born of 3rd degree consanguineous marriage. He's unimmunized, malnourished, with developmental delay in all 4 domains, and has come with fever for around 2 weeks, has pallor with splenohepatomegaly, with silvery grey hair, eyebrows and eyelashes, and generalized hyperpigmentation in sun exposed areas. So keeping in mind this summary, my first differential is storage disorders. Second is, if we consider that this is a syndromic child and now has some tropical infection, so a syndromic child with infection. And third is hemoglobinopathies, because there was history of transfusion and pallor and splenohepatomegaly. Sorry.
So my first question is that how do you look at weight for height or weight for length? How do you do that?
So there's a WHO growth chart, so that using that as a reference.
So you take the weight value and the height value, you actually divide it?
No, we take the length value and then there has to be a corresponding weight according to standard deviations. So according to that chart, the child fits into the -3 to -2 standard deviation category.
Yeah. So do you know what is weightage?
Yes.
What is weightage?
So weight corresponding to the chronological age of the child.
No, that is not weightage. What is weightage?
We plot the weight and then 50th centile corresponding to that age would be the weight age of the child.
So in other words, weightage is the age at which this weight would be the 50th centile. That means bang normal. So when do you expect a child's weight to be 7.2 kg? Normal child, bang normal child, 7.2 kg is at what age?
6-7 months.
Okay, 7 to 8 months, depending on the birth weight, little bit here and there. Length is 70 centimeters. So when do you expect the length of a normal child to be 70 centimeters?
9 months.
Less than 1.
In fact, same, 8 months or so, right? So now our question, this we never understand when you all present, that 8 months upon 8 months, how can it be -3 to -2 standard deviations? Right? So I don't know where we are going wrong, but we need to. So this child has a weight and length, both of approximately 8 months, give or take a little bit, for a chronological age of 13 months. Okay. Now, first thing to understand is that if a disease or nutrition is going to affect a child, what will get affected first? Weight. When will height start getting affected? So after 2-3 months, 4 months. So after that, whenever you see such children, you'll always find that weight is always more affected than height. So this is a pattern that weight is affected more than height. Here weight and height are almost equally affected. So if you plot on the growth chart and if both of them are nearly on the same centile, then you might wonder whether this is the genetic or the constitutional makeup of that child. So to correlate it with a lot of clinical signs, muscle mass, loss of subcutaneous fat, and all those things, and signs of deficiency which we just discussed, right? So that is one thing. Now the second thing is that in your differentials, you said 3 differentials. So why not hemoglobinopathy first?
Because hemoglobinopathies won't account for the developmental delay and the peculiar look that the child has, the hyperpigmentation, the silvery gray hair, and the eyebrows and eyelashes that are present since birth.
Okay.
And they were present with icterus also. He had no icterus.
Okay, so now that's again worth discussing. So if it is a hemoglobinopathy, which hemoglobinopathy are we thinking of at this age? Thal major. Does Thal major have icterus?
No.
So which are the hemolytic anemias which will come with icterus? Everyone else has to speak.
Hereditary spherocytosis,
Okay.
CIHA. But
so hereditary spherocytosis mainly, and then sickle once in a while in a crisis, not like all the time, right? And this is big hepatosplenomegaly with so much pallor at this age. So this is most likely to be Thal major or a combination hemoglobinopathy, right? So not necessarily icterus. Okay, fine. And your other differential was storage disorders. So what kind of storage disorders?
So there are a number of, there can be lysosomal storage disorders, then mucopolysaccharidosis. But for mucopolysaccharidosis, you'll have to have dysmorphic features, dysmorphic facies, which it did not have. Then glycogen storage disorders, a lot of them present very acutely with hypoglycemic episodes during the neonatal period. And that history is also not there. So lysosomal storage disorders can be one of the differentials.
When you talk about storage at this age, the question is it any carbohydrate? But glycogen storage, galactosemia, the presentation would have been much different. So that is out. What about the lipidosis? Infantile Gauches, infantile Niemann-Pick's, but they present with neurological manifestation. Now, this child, he said developmental delay. I found he was quite reactive. Normally, he was looking at us with suspicion. He was quiet there. So he was behaving like a normal 1-year-old. Why are we talking about developmental delay? His cognition looked reasonably good. We haven't tested his language development, but his motor system might have been little delayed because of his weight, etc. But the whole issue is, if you look at a 70 centimeter height, which is like almost 7-8 months,
9 months.
then when did this malnutrition start in this child? Can you guess when it started? How will you guess when was this malnutrition starting in this child? Based on weight and height today.
Mostly at the time of weaning, sir, because of because mostly in such case mother prefers to breastfeed only rather than introducing food.
No, you are right about most malnutrition starting at weaning, but sir is asking because he's 13 months and 70 centimeters today, think of that and tell us when did it start.
70 centimeter would be attained by 8 to 9 months of age. So the malnutrition will start from that 8 to 9 months of age.
It never happens that malnutrition starts at 9 months and button is switched off. Doesn't happen like that. It has to slow down, no? It has to start before that, right? So now, how will you take it backwards? So suppose, what I am trying to explain is, suppose this child was 50 centimeters and malnutrition started. Then would he have reached 70 centimeters? When is he 50? At birth. So if he started malnutrition at birth enough to affect his height soon, would he have reached 70? No. So that means it didn't start at 50. So this is the way you have to think. What is the length at 3 months? 60 to 62, right? So it is possible that he started around 3-4 months or 5 months to reach 70 now over the next 6-8 months.
I think the point is 70 at this age means the first 3-4 months fast growth was not affected. If it had affected, he would not have come up to 70. Okay, first 3 months is faster, the next 3 months is a bit slower, and thereafter next 6 months is even slower. He has gone through the fast period reasonably well. So the story started 4-5 months onwards sometime. Okay. That again means that this is unlikely to be a severe IEM and therefore no storage. Simply by noting where is the onset. And as I said, most of the storage disorder at that age, which are not common, but those who are common, present neurologically with seizures, delayed development, etc. So this is not. This fits in typical. Why syndromic? I imagine this child cognition looked all right from a distance. So no syndromic. So really, we leave it at the hemoglobinopathy and make a note that he is not severely malnourished, not even moderately malnourished. He is certainly mildly falling down, but nothing beyond that. Okay. My question to you is that he has a large liver also. Okay. Do you think it's some disseminated TB to rule out? Do you think he has got an HIV already? Do you think he has got hepatitis B or C from his blood transfusion? Do you think he had got malaria from blood transfusion? So many possibilities. Rule them out one by one. And tell me it's only hemoglobinopathy. Give a thought. Doesn't matter. Yeah. Yeah. Pass on to
PCV, PRC blood transfusion was relatively recent, so any evidence of hepatitis or other disease would be ruled out.
Fine, so that is ruled out. Then
congenital TB would be, the patient would have presented as an abdominal distension in view of hepatosplenomegaly.
Or so it may not be congenital. He may have acquired it later and now it is disseminated.
To present as massive hepatosplenomegaly is unlikely in a 1-year-old to disseminate so fast. Spleen is beyond, it's grade 4, so unlikely.
So again come back to growth. In any child who has a disseminated illness, we just said that weight has to be more affected than height. They can't be parallel to each other, right, in any disease. So that is one very important point, right? And then besides his fever is only 2 weeks and all that. Then what else did sir ask? So one was disseminated TB, one was malaria through blood transfusion. Anybody else? Come on. Think.
Disseminated TB, the child would be very sick. He would have complaints of much prolonged fever, fever and cough, and they will have systemic, very sick looking child. And malaria, very common?
The pattern of fever, high grade fever spikes, and splenomegaly usually in malaria it's not so big. It's
Okay, so splenomegaly is not so big. What else? Icterus. So, do all malaria have icterus? When do they have icterus? Do they have icterus because they are causing hemolysis of the RBCs? Or they have icterus for some other reason? So, you've seen few handful of malarias, yeah? All of them have hemolysis because all of them have RBCs destroyed. Did you see icterus in any one of them? So, hemolysis of RBCs doesn't cause icterus. So, what causes icterus is a hepatopathy. So, in case they get into severe malaria, hepatitis, blockage of the blood vessels of the liver, then they get into icterus, right? But what other reasons for this not being malaria?
Sicker child. Child would be more sick.
Malaria, they are not sick, no?
Mild fever, there should be high grade fever with chill followed by a phase of pattern fever. And cough, cold, malaria, not.
So symptoms don't match, and then you wouldn't have so much of hepatosplenomegaly in a malaria. If you have acute malaria, you'd rather have just a spleen. If you have a liver, then it's a complicated malaria. So clinically, it's not fitting into complicated malaria.
What is the incubation period of all these blood transfusion related infections? I told you several infections go through blood transfusion. What is the incubation period? Suppose I inject by mistake an HIV positive blood. How long will the first manifestation take time to appear? Suppose I give malarial parasite through blood. How long will it take for malarial fever to come? Hepatitis B, C, same way. Tell me the incubation period of transfusion acquired infection. Give a thought. I'm sure Nelson gives all this, but not as an answer to this question. Somewhere hidden in his so many thousands of pages. Then of course you have a CMV, you have many others, but these are common ones. Hepatitis B, C never manifests quickly, long incubation period. Same is HIV. Okay. Congenital HIV may manifest at school age for the first time with only a cortical atrophy and a poor school performance. Depends on how fast is the CD4 going down, how infections come in, but incubation period. Malaria is the only one which you can get straight off. That is a straight introduction of that. For many reasons, I just wanted to give you thought process of how, if you are good in the examination, you are going to pass. But the examiner will trick you to find out whether you are worth a gold medal. Okay. And I'm sure I can see some of you having that gold medal potential, but potential has to be exploited.
Okay. Tell us the investigations.
So, upon investigations, the first two investigations were done in the outside hospital. So, on presentation on 23rd, when he was first presented to the hospital, his hemoglobin was 5.7. The RBC indices, all of them were on the lower side. His WBC count was 4,100, absolute neutrophil count was 1,800, and platelets were 21,000. Then the subsequent investigation in the same hospital revealed 5.5 HB. This is the HB at which the patient was transfused. And there is depression of all three cell lines. The WBC count is 2,400, the absolute neutrophil count has dropped below 1,000, and platelets are 22,000. So this is the investigations done at our hospital. So hemoglobin of 9, again RBC indices show some improvement, probably post-transfusion. WBC count of 2,400 and platelets of 10,000, but the absolute neutrophil count is now 400. So the other investigations were also sent. Probably have deleted that slide. So his dengue, malaria workup was sent for rapid antigen tests. Both of them were negative. HIV, triple H was sent. That was non-reactive. So his total bilirubin was 0.5, OT-BT are 19 and 10, ALP is 271, T protein and albumin is 6.2 and 3.8. RFT is BUN, creatinine 7 and 0.3. Serum electrolytes are for sodium 137.5 and potassium 4.09 and CRP 8.9. His serum cholesterol is 159 and serum triglycerides are high 539. Serum LDH is 364. Ferritin is high 999. PTINR is within normal range. APTT and TT are within normal range. His plasma fibrinogen is on the lower side. It is 95 milligrams per deciliter. So because he had peculiar hair findings, we did a hair shaft examination when he presented to us. So the upper slide is of the child's hair under the microscope. So we can see on the upper image there are clumps of melanin, which are coarse clumps which are unevenly distributed throughout the hair shaft, and the hair shaft itself is hypopigmented. The second image is of the normal hair shaft. So we have sent for his bone marrow biopsy because there is pancytopenia. The bone marrow biopsy and bone marrow aspiration reports are awaited. And we have also sent for soluble CD25 and soluble CD25 levels and NK cell activity. Both the reports are awaited. Blood cultures, urine cultures for this patient are have shown no growth. So my final impression for this child is a 1 year, 1 month old male child born of 3rd degree consanguineous marriage, unimmunized, severely malnourished with developmental delay, has come with fever for 2 weeks with splenohepatomegaly, with developmental delay, pancytopenia and peculiar findings on the hair shaft examination. So most probably this is a case of Griscelli syndrome presenting as primary HLH, primary hemophagocytic lymphohistiocytosis.
You go back to CVC. Just what is your probable diagnosis here? I was going to stop you at there only. I will give you to debate. My diagnosis is aplastic anemia and cytopenia.
No hepatosplenomegaly.
And cytopenia.
Hepatosplenomegaly will not be there in A-plast. Normous.
Sir is asking, just look at this CBC. We are not telling you hepatospleno yes or no. Only on this CBC you discuss.
Aplastic anemia has normochromic normocytic anemia.
Very
usually.
good. Normocytic, normochromic.
Okay. That's why it is not. Then what is the other cause of pancytopenia? Then we start thinking bicytopenia or a pancytopenia. Okay. That would have been a clue. In fact, when I saw this, I was going to stop you there and I said that what is likely to be. Okay. What have we learned? HLH could be always a possibility when you have more than one organ involved, but typically bicytopenia or a pancytopenia. Okay. Surely we would have looked at it primarily as a hemolytic anemia, okay, because of a large spleen, etc. But then we had to corroborate it with family history, etc. And I think this is a good example of what it is.
On this CBC, just on this CBC, can it be thalassemia?
Yeah.
RDW we want to know.
Huh?
We want to know RDW.
RDW you'd want to know, but with that kind of a MCV, what do you think? It's going to be more.
Yes.
So what is not fitting into thalassemia on this CBC?
WBC should be high.
Very good. Why should WBC be high?
The Coulter picks up the NRBCs as
Very
WBCs.
good. So the Coulter picks up the nucleated RBCs. So invariably your WBC is high. So that is your pointer. And then of course pancytopenia. Can thalassemia have pancytopenia?
Associated with any part of it.
Hypersplenism. Very good. But that is usually after a lot of treatment and all that, right? Not at diagnosis, right? Okay. Fine. So I think, yeah.
So could that CBC be a dimorphic anemia with B12 deficiency and iron deficiency?
Which the first one?
MCV being 60. Could it be dimorphic with iron and B12 deficiency?
It could be, but actually, so see, when MCV is low, 60 is also low only. So you would rather jump to iron deficiency only. So that is not an indicator of dimorphic. So how do you suspect dimorphic? You have a low hemoglobin and you surprisingly have a not so bad MCV. Then you wonder whether the microcytic of iron deficiency and the macrocytic of B12 is getting averaged out to get you not so bad a MCV. But of course the smear will show a dirty smear and your RDW will be very wide because you have all sizes of cells, big, small, this, that. So you have a very wide RDW. So a low hemoglobin, MCV is surprisingly not so low, and a wide RDW will tell you that this might be dimorphic, and look at the smear and you will see a lot of variation. Anything else? Sridhar, anything else on? Okay.
Third degree consanguinity was always to be kept at the back of my mind. This child, particular child, seems to be having. There are many types of oculocutaneous albinisms. You can have only hair changes, you can have only eye changes, and all of them. And this was one of my research points in KM where we had to see all albinisms and see their hair under the microscope, whether it is positive for melanin or no. So I was very happy to have this study done here for that, and there are some other syndrome. But sir, this child does look malnourished. I mean, 1 year, 1 month old child, he looks reasonably thin, his muscle mass is poor, the subcutaneous fat is not so bad. So he looks more malnourished than what the statistics say. And also I would have liked you to give a little more details of cognitive milestones. We understand the gross motor milestones. He didn't look all that bad for cognitive milestones. So to call it delay in all the fields of milestones, we would have had little more details of cognitive milestones. At 8 months, 9 months, it's difficult to judge cognitive milestones where simultaneously physical milestones are also delayed. And you have to pick up those which are independent of that. For example, for an 8-month-old child, peekaboo is a good milestone. Earlier than recognition of a stranger is a good milestone. So pick up those milestones which are independent of gross, but only tells you only tells the cognitive milestones.
There was a mention about Hermansky-Pundlach syndrome because we are talking about albinism. That's one place where you do platelet function test. Because suppose you have a Muslim community and they want to do a circumcision, it can continue to bleed. So just don't get the platelets. You have to do a platelet function test.
Fine. So we'll stop here. So thank you very much. Thank you all our online viewers and the online faculty who were watching. And we meet once again next Thursday evening at 6 p.m. And again a request to all students, those who are in Mumbai, to please come here physically and attend because there's a lot of interaction and a lot of learning. And those who are not in Mumbai can always join online. Post your questions, join the Zoom link first because you can post your questions and we can discuss your questions or your answers to our questions. So thank you once again, and we once again at the end of today's session thank both Sion Hospital and Aristo Pharma for giving us a academic grant which facilitates the live relay of these classes every Thursday. Thank you very much. We meet once again. Okay. I'll just, we have a representative of...
Please come.
We have Dr. Pankaj Shirke from Aristo Pharma who has facilitated this webcast. So
it was because of him that we get this webcast done. Thank you
so
very
we
much
thank
for being
him,
here.
we thank him for this.
No, sir. Thank you very much. And this is the least we could do, sir. Even I enjoyed sitting in the back. That this is a pure scientific program. And everyone, I would request every student to join this program, because definitely the program was very interactive, and I wish I could join you every Thursday. So thank you very much.
Thank you. Thank you. So thank you, viewers, and we meet next Thursday at 6 p.m. Thank you.